Good afternoon to everybody. Happy to be here. Today is about dementias and different types of dementias. So could be boring a little bit, could be. So we can spice it up by you interrupt me at any time if I'm not clear, if you have any question, okay? And I'll try to give you a gist. And while I was preparing the presentation, which by the way, helps me to keep up with the topic so that I don't forget any part. While I was making the presentation, I realized how much there is in talking about the different types of dementia, and we've come a long, long way. Since, well, I first started my graduation and then PhD courses. And so let's try to make it relevant. Stop me where, again, I already said that, so I will move on. Dementia. Dementia is a... Here you go. And here you go. Okay. So, not panicking, not letting the anxiety. Where is it? There must be. Okay. So sorry. No, got it. Yes. Error, trials, and learn, hopefully. So dementia is a big umbrella of symptoms that entails cognitive, mood, and behavioral changes that are not normal for age and not normal for the person's way of being. Okay, so dementia is a big umbrella of symptoms, okay? Changes in cognition, memory, attention, visuospatial, executive functioning, problem solving, organization, planning, but also different types of symptoms as regard mood. So from depression to apathy, to restlessness, to agitation, inappropriate behaviors, irrational thinking, unusual suspiciousness, hallucination, and so forth. Now, when a person experiences these type of symptoms and after a neuropsychological evaluation, we can say there is a dementia. Now, the most important part is to see what is causing dementia. So when we say Alzheimer's, frontal lobe, temporal dementia, a different type, we are talking about the causes of dementia. So this is to answer one of the most common questions, saying, what's the difference between dementia and Alzheimer's? What's the difference between, well, dementia is a cognitive and mood and behavioral decline. And Alzheimer, Lewy body dementia, frontotemporal dementia, those are, and many other are causes, okay? So this is the main point. When you experience changes, you go to the neurologist. The neurologist is your doctor. The neurologist will do a workup for dementia, which includes a diagnostic interview, an interview to the client, to the family members, see what's going on, what happened, neurological exam, okay, motor, sensory, a brief cognitive screening just to see. We have now the mini-mental state you probably heard of. MOCA is another one, and performance under certain scores will warrant more in-depth evaluation, lab work, neuroimaging, and a neuropsychological evaluation, which for now is the gold standard to see if there is dementia, if it's a normal aging versus something different, and then what patterns of cognitive dysfunction, which will guide the neurologist to, and he will put it together with the other information he has. And as soon as there are changes that are not right, that are not as expected for that person, and Going to a neurologist is really important, talking to a physician, eventually a neurologist, because there are reversible causes of dementia. So the dementia, the umbrella with the mood, cognitive, personality disorder could change, could improve if the causes is a reversible one, something that can be treated. Most of the causes are usually progressive, like Alzheimer's, vascular dementia, Lewy body, frontotemporal, chronic traumatic encephalopathy, posterior cortical atrophy. So those are the neurodegenerative ones, and those are progressive once they are diagnosed. But before diagnosing, the neurologist will rule out all the reversible causes because the symptoms are the same. So yes, we have now more neuroimaging, more lab works, but still this is the process. So what are the reversible causes to have a memory impairment? Those are depression, thyroid problems, diabetes, vitamin B12 deficiencies, dehydration, some medication side effects, subdural bleeding, infections, autoimmune disorders, normal pressure hydrocephalus. Those are all reversible causes. And I'm not even mentioning all of them because this is more, the neurologist, but those are the major ones, okay? So the diagnosis usually is by exclusion from the neurologist who uses different tools. Talking about Alzheimer's disease. Alzheimer's disease is the most common cause of dementia. It accounts for 60–70% of all dementias and usually starts after age 65. There's Alzheimer's, a type of Alzheimer's that starts before age 65, and this is more aggressive course, but also there's more family history of, like a predominant or like that does not skip, for example, generation. The mother, the grandparent, and so forth. So, but let's talk about the course of the Alzheimer's disease pre-senile that, of course, earlier is similar, but just more rapid, more dramatic. The causes are genetic in small percentage. Apolipoprotein E4 is a genetic variant that can be seen, but also environmental and lifestyle. So far, the cause of Alzheimer's disease is not known. Okay, so we are pointing in the right directions, and one cause is inflammation. So they're also looking at the inflammation processing, what's going on, but the cause of Alzheimer's, why this is happening, the first step, we still don't know. So we know the cascade of events, and now we are being more precise about the cascade of events that are occurring. Mechanism is abnormal deposit of these protein form, beta amyloid plaques and tau protein that forms the tangles. And this is, those are images. I hope you can see them. I hope, because maybe would it be possible to, it's better on the video than here, to maybe lower those lights, just, Linda is doing it, yeah. But anyway, this is a healthy neuron, the nuclei, the axon somewhere, the dendrites, and those are the beta amyloid plaques that form and entangle. Those are the dendrites and the axons that transmit and receive information from the neuron. This is the nuclei. In the nuclei, there's the tau protein, so the neurofibrillary tangles. And by accumulating, they destroy the cells, the nucleus. Therefore, they do not allow the neurons to perform their functions, to repair themselves, to transmit impulses, and to do their own the processes inside the nucleus to receive and transmit information properly. And therefore, the neurons, little by little, because they don't receive any supply, and so they will die. And although we have billions of neurons. By dying, they would create areas of atrophy in the brain. This is just an image that says those are healthy neurons, two neurons communicating through the axons, and the transmission of the impulses from one neuron to another is electrochemical. And at the chemical level here, there are the synapses that release and receive neurotransmitters, the way they talk to each other. One of those is acetylcholine, and that's why donepezil, for example, was created. Donepezil is one of the first medications that came in order to work at this level to make acetylcholine more available through a mechanism which is not important now to say. Yeah, that would be too detailed for my brain. Okay, so Alzheimer. There's a scale to verify the clinical progression of Alzheimer's that you can see online. It's called Global Deterioration Scale. I've been using this since 1991, since I first started to work in a lab with a neuropsychological lab. And this scale was created by Risberg, which are scientists, the neurologists from Sweden. Anyway, this is still very precise and quite accurate in describe the phases of progression of Alzheimer's. I'm saying Alzheimer's and not necessarily all the other dementias, because the other dementia may have slightly different course, but these explain really well what happens. So when I see my clients, I provide them with, the scale if they want to upon request, because sometimes you don't want to know too far ahead, but it's really describes really well the clinical presentation from initial forgetfulness to needing more supervision. And then another step is unable to functioning without someone that will supervise the person and so forth. So it's a seven stages. So I thought, and you can find it online because nurses and physicians, they use. The cognitive deficits in Alzheimer's disease encompass the 5 A's: amnesia, aphasia, praxia, agnosia, and awareness. Amnesia is rapid forgetfulness. And this differentiates Alzheimer's from all the other types of dementias, the rapid forgetfulness. So the person will be told something to learn, and then after a while, the patient will be unable to repeat, to recall the information, even upon recognition. So do you know when you have the tip of the tongue phenomenon and you say, well, what's the name of that actress, right? But then if someone tells you 2 or 3 names, then you say, oh yeah, that's it. A person with Alzheimer cannot benefit, that will not benefit from it. It won't, because the information is gone. That is the amnesia. Aphasia, language problems, problem retrieving words, and then also the semantic, the meaning of words starts over time to degrade. Apraxia, inability to perform complex tasks with your hands without having any movement disorder. So complex actions like preparing a coffee or even writing, the person will miss the sequence of the movement. That's apraxia. Agnosia is when Alzheimer's has more a visuospatial deficit that is predominant. So it's more memory and visuospatial rather than memory and language. And awareness is the gradual lack of insight, the gradual lack of how am I doing? What are my limitations and what are my strengths? So during a clinical interview, a person with dementia in the mild stage would say, I don't know why I'm here. She wants or he wants me to be here. but honestly, I'm good, actually. You have to test him or her because, so that is the lack of insight when the spouse is saying, hey, it's not really like that. There are then behavioral psychiatric symptoms with Alzheimer's, aside from anxiety, depression, lack of interest, apathy. There's also wandering, pacing, hitting objects. This is not at the very beginning. This is towards the middle, late stages of hiding things, not remembering where put, and then thinking that someone took those belongings and being adamant that there's no other explanation. Infidelity, so those are irrational beliefs. Capgras syndrome, which is when the patient does not remember and does not recognize the spouse, and therefore thinking it's an imposter or a double. So, for example, a client saying, I don't know why this year, but Mary wouldn't do that. I don't know where Mary is. This other person shows up every morning. I find, and they don't want this person in the bed, for example, things like that. Sexual activity changes, hallucinations, seeing things that are not there, changes in appetite, sleep disturbances. I would say that with Alzheimer's is like a slowly but progressive weakening of the functions. There's nothing dramatic, but when the cognitive changes are severe, then there are more these behavioral problems. And by the way, these behavioral problems can be addressed if once the caregiver is instructed of why they're happening. So there's a lot of things that can be done in order not to see any violence. You know, a person with Alzheimer's is not violent. It's just, if there's violence, is because the caregiver, the spouse, or whom, they are not doing the right thing with the patient. So go and see a neuropsychologist, because can be completely avoided. Vascular dementia. How are you doing so far? Because yes, good. Second most common, 50-30%. So those are data that you find online, that you see in the different reviews. And onset usually afterward 60s, 70s, and after can be sudden if there was like a TIA or a stroke. Progression is stepwise. While the progression of dementia is gradual, but a gradual, smooth decline, so we say smooth progression, vascular dementia is stepwise. And so most are other forms of dementia. So there's a plateau reached for a while, and then there's a loss of ability in some area, and then there's a plateau, and then there's a loss of in another area. The vascular damages through blood clot, stroke, TIA, and of course the damage of the fibers that transmit the impulses, because when there's vascular damage, then we always have to think about the transmission of the impulses to one another, of the neurons. Inflammation is a mechanism, and risk factors are hypertension, diabetes, heart disease, and stroke. So that is why everywhere you turn, if you go to a doctor, what do they say? Blood sugar, treat hypertension, treat diabetes, lose weight, eat healthy, exercise. Those are all recommendations to treat vascular problems. Cognitive deficits, we start seeing some psychomotor slowing, because with vascular dementia, as I said, the problem is in the blood vessels that nourish the neurons, and there are problems with the myelin sheath that is covers the axons. Those are the one transmitted impulses. So since this myelin sheath, which is fat, you know, is not smooth, then the impulses from one neuron to another will slow down any activity, cognitive activity or motor activity. So we start seeing psychomotor slowing, decreased concentration, and the memory problems, opposite of Alzheimer's, are more retrieval than rapid forgetfulness. So with these types of dementias, vascular dementia, and also Lewy body dementia, the memory problem is always retrieving the information, but the information is mostly in the brain. It's difficult to retrieve it, which is similar to what we usually experience on a daily basis, right? What's the name of this? I went to the restaurant, what's the name of, but upon recognition, we would know. So this is the difficulty with retrieval rather than retaining any information. Lewy body dementia, third cause of dementia, 20% onset after 50s, progressive. The causes is abnormal deposit of alpha-synuclein, and which is called Lewy bodies, and the alpha-synuclein protein, these abnormal unfolding that clot the neurons is seen in Lewy body, Alzheimer's, and Parkinson, There's it's not normally considered a genetic disorder, and there are no specific lifestyle factors associated with it, which we can find in the vascular dementia. Vascular dementia is, they say, completely preventable because the lifestyle factors play such an important role. Inflammation. Here, they still don't know why. The cognitive deficits are fluctuations in attention, so often referred as staring in space, concentration, difficulty concentration, multitasking in thinking, visuospatial problems, and memory is not the first cognitive. So memory starts to decline a little later, or during a neuropsychological evaluation, executive function, visuospatial are more impaired than memory at the beginning. Other criteria are slowness of movements, pauses, stiffness, tremor at rest, falls, unexplained falls, visual hallucinations, REM sleep behavior disorder, which is acting out in the dreams, and then mood problems, depression, anxiety, lack of interest, agitation, and restlessness. As you can see, the symptoms of the dementias overlap. And that's because this is what the neurons do. They manage cognitive mood, personality changes, and all the biological needs. But some dementias, creates more symptoms in one area than another. This is something that clinically. And this is still an applied rule when there are motor problems and then cognitive problems. It's so important to know the chronological order of the symptoms, because with Parkinson dementia, usually everything starts with movement disorder, and then eventually there might be cognitive difficulties. With Lewy body dementia, is the opposite. There are cognitive difficulties, there are changes cognitively in personality, and then the movement problems will follow. Of course, the neurologist is the one to make the proper differential diagnosis. Why Parkinson's disease dementia is not among the causes that I told you at the beginning under the umbrella? Because it's not, with Parkinson, you don't necessarily end up with the dementia. So about 30% will progress from into dementia, but mostly it's mild cognitive impairment. So there are cognitive changes, but they are not as severe as to fulfill the criteria of dementia. Okay, and the cognitive deficits with Parkinson are psychomotor disorders, in psychomotor slowness, in executive functioning, visuospatial function, and memory in the form of retrieving. I think this is the last one that I'm And frontotemporal dementia, you're familiar with, you know about it? No? Yes? See. So frontotemporal dementia is a type of dementia where the neurodegeneration, again, caused by an accumulation and unfolding and accumulation of protein abnormal, is mostly in the frontal, prefrontal cortex, and temporal lobes, okay? So that's why it's called frontotemporal dementia, because the areas involved are here and here. So that's what you expect to see in imaging. On a PET scan, on a MRI of the brain, that's where the doctor expects to see. But let me tell you, sometimes, particularly at the beginning, there's no real full correlation between clinical symptoms and neuroimaging. So that what makes it at times really difficult. So maybe the neuroimaging is normal and cognitive is a disaster. And sometimes it's the opposite. Cognitive is not that bad, but the imaging, I say, wow, there's a lot of atrophy here, okay? So that what makes it challenging for the clinician. But anyway, relatively rare. Onset is early, is early. Before 65 is gradual, insidious, rapid, pretty rapid progression. Rapid progression was, am I talking about 5 years, 7 years? Pretty rapid changes. Again, genetic mutations can be part of it, abnormal tau and TDP43 protein. Don't ask me much about this protein, but that's what they see in that's what they see as part of, again, but the mechanism is the same. So all these proteins entangle and cause a destruction of the neurons and therefore their functions, their ability to regenerate and ability to transmit impulses. Frontotemporal dementia has many variants. Okay, so there are two major variants. One is behavioral variant, and the other one. So the behavioral variant is the one that affects more the prefrontal cortex. And then there's the primary progressive aphasia variant that affects most the language. Okay, talking about the behavioral variant, needless to say, it's in the name. The main problem that changes that the spouse and the family members and the friends will notice are behavioral. So the person will start to act in a way that is not Bill, that is not Mary anymore. I mean, that's really out of character for Mary to say, to do this. Or so apathy and disinhibition, lack of restraint. So in social situation, doing something inappropriate, doing something that he or she would never have done. Refraining from embarrassing situations, so saying things or that are not really appropriate, and they wouldn't care much if they wouldn't know, the person wouldn't know if that causes embarrassment. It wouldn't be empathetic enough to say, oh, I'm saying something or doing something and my family will be embarrassed for me. No. Why? Because the centers for insight are affected among the first problems that are, therefore, there are changes in empathy. So difficulty for the person with frontotemporal dementia to put himself or herself in someone else's shoes and say, maybe I shouldn't have said that or I shouldn't that. No, it's not possible. Lack of insight. Compulsive behavior, so start collecting, could be collecting things, humming, throat clearing, repetitive checking, arranging items, taking the items off the toolbox, the organized toolbox, okay? Taking the item off and rearranging them in boxes in a completely inefficient way. Spending hours and hours and hours to undo something that was really clean and organized for anybody else to something that does not have any meaning. That is alter food preferences and hypersexuality, yes, not the major ones. So, and then of course there's also cognitive impairment, but the first symptoms, clinical symptoms, are personality changes. In the second form of frontotemporal dementia, primary progressive aphasia. Now, I don't want to go into the details. I'm going to summarize these. There are two variants. One is semantic. So the person mostly loses the understanding of the meaning of words and things. So unable to name this. Not because cannot recognize, but the concept of a cell phone is degrading in the mind. So, and the other one is agrammatism and non-fluency. So difficulty saying, being fluent in a conversation, the syntax of during a conversation will be dysregulated, impaired comprehension, a 4/4 halting speech. So gasping for words and then not really know what other word to choose. So very painful, even to the patient, because in this form, at least at the beginning, the patient is aware. Is more aware because it does not involve necessarily the prefrontal cortex as in the behavioral variant. So really not fun. Okay, this is to show. Then there are frontotemporal dementia that are movement related, is a tauopathies, is more a tau, the tau protein that affect this, and those are progressive supranuclear palsy, corticobasal degeneration. I'm not going into those. Those are more for the neurologist because, so the neurologist might send me a patient with primary progressive supranuclear palsy and say, how is the person doing? Is there dementia, mild cognitive impairment? And then I will see, but I'm not expecting any particular there was a nice table. So about the different type of, or the most important protein problems per divided by Huntington disease, which is a genetic type of dementia. I'm not mentioning it because there's a hereditary. So you would know if you are at risk of developing Huntington disease. Parkinson disease, the alpha-synuclein, dementia with Lewy body, amyloid and alpha-synuclein, Alzheimer's, tau and beta amyloid, frontotemporal dementia, the tau, the DPT-43, and the chronic traumatic encephalopathy. This is when a person has sustained repetitive, multiple concussions over a lifetime. It starts an inflammation process that can cause dementia. Okay, so that's why individuals with concussion, multiple concussion, are at higher risk than the general population of developing dementia in the future. How are we doing? 36. I will skip this. Okay. We have dementia, but before dementia, along the continuum is normal age-related changes. On the other hand, there is dementia. What's in between? Mild cognitive impairment. Okay. Again, the neuropsychologist determine the amount because, you know, so far we have the best tools to do it. So mild cognitive impairment usually is amnestic type, meaning there's memory involvement. Many times is non-amnestic. So the main problem is visuospatial problems. So this is just to say that there is a impaired memory, yes or no. If yes, only memory, or so this is a classification which is not particularly relevant. It was particularly relevant at the time that this came in 2004, 2001, 2004. At that point, it was something new. Now it's not something new 20 years later. But still, when I write a report, I say it's mild cognitive impairment, mostly amnestic, or mild cognitive impairment, mostly visuospatial or non-amnestic. The conversion of having MCI puts a person at a greater risk to develop dementia, but not a certainty. to develop dementia. Actually, having been diagnosed early make you in the position to do a lot of prevention, a lot of work in order to, so if you are diagnosed early with Parkinson's disease, early, then you can really expect a long time of stability because you are exercising the brain the right way, and the same with vascular dementia, the same with when you have mild cognitive impairment, in order to stay in the mild cognitive impairment area or even improve. So that's what this says. Early intervention, early detection is always good. I already talked about neuropsychological evaluation. Are you familiar with the neuropsychological evaluation? Is some testing, usually paper and pencil, where that measure attention, executive function, different types of attention, different types of executive function, different types of memory, visuospatial abilities, emotional changes, behavioral changes, all embedded in how are you doing in your normal environment. So for neuropsychological evaluation, there's a huge portion which is asking the family and the patient how they are doing, what are the, so if these changes are how much they are affecting daily functioning, which is all it is about. Because mild cognitive impairment, the criteria means abnormal memory, but in a relatively preserved ability to function on daily tasks, daily activities. Dementia is memory plus at least an impairment in one other area, like visuospatial, executive, or language, but these problems are really affecting the persons to be independent in daily life activities. So those are the two. So that's why it's important during when you go to the doctor, and they will ask about the impact in daily life activities. So, and personally, I am really a firm believer of getting the symptoms in chronological order. Because if we don't do that, then we may miss a lot of information. So a person would start saying, I have this pain, I had a brain injury, I had an inflammation, I have, you know, and they say maybe have. So when did that happen? And after that, when, particularly those that have a medical complex medical history. So chronological order of the symptoms important, even for you. So as a patient, when did I start feeling this? This pain in the, you know, in the hip. When did I start? I put it on my calendar just to remind me. When did I start to have experienced these symptoms, so that you can keep track and then tell the doctor more precisely. Oh, that happened when you were introduced, when you know, I was introduced to this medication, or that happened when I went on vacation in Thailand, or when I went in vacation into Connecticut and went into the woods. Those are all relevant information for the doctor to try to figure out what's going on. Okay. Ready for a little memory test? I would like you to, so I'll keep it like, let's say 30 seconds. There are 6 words that I would like you to try to learn. Try to use associations if you can, either visualization, or try to read them over and over and try to make any connection, association, in order to try to keep them in your memory. Ready? Okay. I'll read them once. Bird, table, song, green, eraser, chair. Bird, table, song, green, eraser, chair. Okay. Now, I'm gonna say some numbers and you repeat them soon after me. 3, 7, 2. 4914. And now backwards. I'm going to say two numbers. You repeat them from the last to the first one. 2, 4, 7, 9. Okay. Now I'm going to say some numbers. And every time I say the number 5, you lift the hand. Okay. 7, 2, 4, 5, 2, 5, 5, 1, 7, 8, 5, 2, 4. Very good. And what was the other thing that I wanted to? Okay, yeah. Try to say out loud by yourself as many words beginning with the letter D that you can think of. D. David, Trump, dust, song, bingo, dog. Not easy. Okay, stop. Very good. This is a visuospatial task, and don't want you to name anything because it's a little bit is one possible test administered in order to see the visuospatial, because there are so many lines that the visuospatial ability is to identify each object that are overlapped. This is another visuospatial task in daily life. I'm sorry, this is not clear enough, but these are two cups, but one in one perspective and this other one in a different perspective. So if a person has visuospatial impairment, it is difficult, more difficult than normal to find, to identify. So those are just, when I say visuospatial, I just wanted to give you what it is. Okay, recall, words. Very good. So this is in a memory task is the delayed recall, what we call it, right? We made it very short because just, only 3 minutes in between. But now, and this is the recognition portion of the same test. So a person with dementia of the Alzheimer's type would have really a hard time to repeat, but also to recognize. So this is the recognition portion. There are the 6 words are here mixed with other words that were never presented. So usually this facilitates, let's say a person recalled 4 or 5 out of 6 or 2 out of 6. With this one, if it's a retrieval problem, would be able to facilitate recall, right? So here's go the bird, the table, the chair, the green, the song, the eraser. Okay. Okay, so immediate repetition, which we didn't do because I just had you to read them, then delayed recall and the recognition portion. In a memory task, there must always be a recognition portion. Otherwise, you don't know why the patient was not able to recall, because he forgot completely, therefore failing this, or because, instead retrieval problem and would ace this. So those are completely 2 different mechanisms that also will guide me and therefore the neurologist to the type of dementia. In Alzheimer's, like I said, so Parkinson, Lewy body dementia, those have retrieval difficulties. So they would do well on a recognition. Depression, never underestimate depression if it's something always present, okay? Because depression can be a symptom of a beginning of neurodegenerative problem, could be the beginning of, could be a pure depression. So if the person is, or endogenous depression like you, okay. But because it's shared by so many problems, autoimmune disorder, encephalopathies, inflammation, neurodegenerative process, normal aging, it's important to always to address. and or have a discussion with the doctor. And this is one of the most common referral question for me, for a neuropsychologist. So is this, the patient is complaining of memory problems, but I don't know about, is it more depression or is it a dementia? And with the neuropsychological evaluation, there's a possibility to distinguish the two. I told you about neuroinflammation, inflammation of the brain and spine, the brain tissue. Neuroinflammation is a process that they think is underlying. So maybe in another 10 years, no, maybe in another 2 years, because now we are going so fast with the research, maybe in another 2 years, now that we know that there's an unfolding problem of the protein affecting neuronal functioning, maybe they will go further and say, okay, for sure, we know that there's another cause that causes the unfolding of the protein. And the neuroinflammation is one of the causes that they are looking at. The glia, the type of cells that nourish the neurons that are part of the play an important role in inflammation. And as this, you don't see very, very well here, but the original image is better. So inflammation has benefits and disadvantages. The benefits of neuroinflammation, because we have it, means we need it, all right? Inflammation is an alert of the body saying, hey, something is not right. And so we are equipped to control and to put out the fire of the inflammation right away. If that does not happen, then because something is not right, and then the inflammation exacerbates, causing more damage, a cascade of events, because the inflammation is not doing its job, okay? So we need to do anything that we know of in our lifestyle to reduce inflammation. And again, exercise, good nutrition, good sleep, stay calm, address the stressors. If any emotional, address it, and such. Pharmacological treatments. For a long time, we only had cholinesterase inhibitors. As I said, that donepezil, for example, and alike, that they are trying to make sure that there's enough acetylcholine or other types of neurotransmitters by killing the enzymes that are killing the neurotransmitter. It's not very scientific, I know. But anyway, for a long time, we have donepezil. Everybody was really happy when now that we are trying to go into different type of treatments. So far, though, this is the thing. Dementias are not treatable, are curable, cannot be cured, but treatment focus on the symptoms. This is where we are right now, although there's a lot of hope. Antidepressant can be used to address certain symptoms, same with anxiolytic, antipsychotic of second generation. And why? Because the antipsychotic of first generation are inhibit dopamine. So they would create mood problems, movement problems. So anyway, lecanemab. Leqembi, have you heard about it? Yes? Have you heard about lecanemab? Because of the unfolding of the proteins, now the research is trying to target the beta amyloid. So it's trying to, so since the cell is not, the neurons is not able to get rid of the amyloid as it does because we have amyloid in the brain and our brain is usually able to get rid of it. We have tau and the brain is stable. The healthy brain can manage the tau in the small quantities and the tau is not misfolding. But when there's something we don't know that unfold the proteins, now do we have an abnormal amount of these proteins that are causing the neurodegeneration of the neurons. Therefore, the treatments are trying to address and target and to remove these, for example, excessive quantities of beta amyloid. One of these is the lecanemab. The lecanemab is intravenous. but it was approved. It's the one that was approved fast from the Food and Drug Administration. I don't know about it. You have to, in case you want to know more about it, not because it's a treatment for Parkinson, no, but ask Dr. Gonzalez, because we're still in the initial phase of this type of treatments. There are side effects, there are, I don't know. But again, better to ask Dr. Gonzalez or your neurologist. And my message here is that from just the anticholinesterase inhibitors like donepezil, now we've come a long way, and the research is going so fast that it's so difficult to keep up with all the new. It's really challenging to keep up with the new with the new findings and the clinical trials and everything that is going on. Thank God for those, for example, for Parkinson, thank God for the association, the Parkinson Foundation, the Michael J. Fox and everything. They are keeping up with the research, and then they're able to send us newsletter with summary of what's going on. Okay. After a diagnosis of dementia, what do we do? Well, when I first started working with dementia in 1991, what I saw was, okay, I'm sorry, you have dementia, I'll see you next year. That was basically what was in Genoa at that time. Donepezil was still to come, and there was no association, Alzheimer's Association in Genoa, which is a big town, and no daycare centers, no caregiver support, no educational, like class, nothing. So that was really, I'll see you next year. We've come a long, 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 long way. So we have now so much that we can do. So this is very nice. Those are good points. It's a better understanding of symptoms, first of all. I was reading about, I was reading about the story of the actor Robin Williams, and the fact that apparently they were very confused by his symptoms, and before coming to a proper diagnosis, him and his wife took a long time. So in certain situation, having a diagnosis like, oh, now I understand what's going on. Now this has a name. Gain perspective, define and embrace what life may look like moving forward. Allow time to review your options and making decision. Accessibility of family, friends, neighbors, church, community. So try to gather what's your people now around in order to make sure that you have enough support and put together an action plan. We know there are support groups, there are different forms of association, there are Facebook online groups, local care home agencies, so adult day programs. So now there is a lot that we can decide to okay, we can make a decision, say, okay, I would like to have help from all these. After a diagnosis of dementia, really important to address legal issues, financial matters, really important. Medical care, healthcare surrogate, just, which, by the way, this would be something that we do generally as we age. So nothing. Okay. Those are thank you. Those are the risk, well, I've told you already that can be changed in order to reduce risk of dementia, lifestyle interventions, diet, exercise, anything that you hear from here, from the providers here, anything that you are doing, those are his sleep problems, medicine. Okay. Brief mentioning of 2 factors. Do you take Benadryl every time or do you know of anybody that takes Benadryl every night for years in order to be able to sleep? Benadryl contains diphenhydramine, which is it's an anticholinesterase, meaning that it affects the acetylcholine, therefore memory. So Benadryl equals bad memory in the long run, once in a while, but there are people that use it not for as an antihistamine, but as a sleep aid, over the counter, easily access, bad decision. Or over the years, I'm talking continuously, meaning not in moderation. Second, alcohol. Unfortunately, this is something that it's important to say. Alcohol is in moderation is good, in larger quantities, which is 7 drinks per week for more than seven drinks per week for females, and 14 or more drinks per week for males. In the long run is bad and causes a lot of cardiovascular damage. So those are things that are part of lifestyle intervention that is important to know, because when you realize there is a problem and you can't go to the neurologist or neuropsychologist, then it might be late to go back. On a good note, brain is plastic. So neuroplasticity is something that every time we learn something new, there's a reflection in newer connection in the brain. So that is why all the exercises and all the classes here at Parkinson are just targeting neuroplasticity. That's how good you're doing to yourself. And that's how good we're doing if we keep a good daily routine, which include diet, exercise, good sleep, lower stress. And there's a fifth one. I said them too fast, but okay. Neuroplasticity. Exercise, nutrition, stress measures, sleep hygiene, do novel, non-routine activities. What would be a non-routine activity? Something that, to change an activity in your routine, what can you do to do it differently? Yes, dance, because yes, exactly. Or another activity that you do routinely. The example comes to my mind is brushing your teeth with the different hand. Try to write with the other hand, because if you're going to use the motor cortex activating the finger, but is on the opposite side of the brain, of the one that you usually use, of your dominant hand. So if I am left-handed, my dominant motor cortex is here. So this is what activates. So sometimes I challenge myself to, do circle or something precise with the other hand, because I'm moving more this one. They are not coordinated, but by doing this, I make them move. And cognitive reserve. The more we study, the more we are engaged in life, the more we are involved and have something meaningful in our life, the more the active our lifestyle is, the more connection we create. And we should know from when we are young to do all this, so we come equipped. That's a good tool to have as we age and things start to happen that we want or not. And that's it. I would say thank you. Any question? Thank you. Thank you so much.